the Clinical Technical Assistance Center's Clinical Lunch and Learn on working with older adults in mental health services. We're very excited to be presenting this topic to you today. I think it's the first time that we're really focusing on the older adult population, and we're going to be very excited to hear your feedback after viewing this webinar, as there was a lot of content we wanted to present to you today, and if you'd be interested in seeing a part 2 to this training or this webinar, we'd be happy to do that. So at the end of the webinar, there's going to be a feedback survey that pops up. Please just let us know if you'd be interested in what specifically you'd like to hear in an additional webinar. So before I introduce our wonderful presenter today, Dr. Ampere, I just want to go through some quick housekeeping. So this is a 1-hour webinar. Everybody is currently muted. So you will be hearing the presentation primarily through your phone, so please make sure that you have called in using the conference call number. If at any point you have any questions, you can use the chat box that is on the right-hand side of your screen in that panel and type in your answer in the bottom box and then click send to all panelists, and that way we'll see those questions. And if we can answer them during the webinar, we will. Otherwise, we'll answer them at the end in our Q&A at the end. So without further ado, I would like to get started on this wonderful presentation. We have here Dr. Madi Ampere, who's a clinical social worker and the director of Alzheimer's Disease Assistance Center at Mount Sinai School of Medicine here in New York. She has an extensive experience working with older adults, both clinically as well as through program or research projects, and she has a wealth of experience that she's going to bring to you today. Thank you very much for joining us, Dr. Ampere. I'm just going to hand it over to you.
Hello, I am delighted to join you this afternoon and look forward to your comments and feedback. And today we're going to be speaking about working with older adults in mental health services. And as you know, there's a lot of stigma associated to mental illness, and that really is a barrier to for older adults to seek care and also to receive necessary treatment. As you know, untreated mental illness in older adults affects their health outcomes in general, as there are high medical comorbidities, increased disability, mortality, quality of life issues, and in addition, a very high cost to the underutilization of mental health services in this group. That is, as you can see, growing exponentially. In this slide, you'll see that there are about 10,000 baby boomers in the United States that will be turning 65 every day until 2030. That will impact all of us. Either we're going to be one of the older adults, or we're going to be related to an older adult, or we're going to be working with an older adult, which is why we are meeting today. Specifically, we are interested in hearing about your experiences in working with older adults. Specifically, what percentage of your caseloads consist of clients over age 65? We're interested in these particular populations since we know that people are living longer. They're living longer, sometimes healthier, but sometimes they're living longer and their health situation is not optimal. So those are the types of patients that sometimes present to mental health services.
So you have a polling question that has popped up on the right-hand side. Please click your best answer, and we're going to give everybody just a few seconds. And then when we're done, we're going to see everybody's responses, and we're going to talk about it briefly. So please go ahead and click your best response. And we would like everybody to participate because it's particularly helpful to see where everybody is in working with this population. Okay, so the results are going to pop up shortly. Sometimes there's a slight delay. So what we're interested here is really seeing what is the percentage of caseloads out there, especially since Dr. Ampere mentioned that there's this tsunami of potential people that may be coming to your clinics. So wow, that's really interesting. It's a nice breakdown. So of those who were able to answer, about a quarter are seeing between 0 to 25%, but there's quite a bit of you that are really looking at either half of your caseloads or much higher. Thank you very much for responding. We actually want to also ask you a slightly different question. So now what we want to see is what percentage of your caseloads consist of clients over 80? Now, before we had asked over 65. Now, this is really a much older population, over 80. So the same thing, please click in your panel which percentage of clients you see who are over 80, 0 to 25%, 25 to 50%, 50 to 75%, or 75 to 100%. Okay, and then just in a few seconds, we'll see those results as well. And this is going to be particularly interesting to see as well. Okay, I think we're going to see the results right now. And there's just a slight delay. And as before, the over 65, there were a quarter of you that were under 25%, but many of you were really reaching 50% or more. And here, actually, we're seeing sort of a different breakdown. So for this older population, over 80, what we see is that most of you really have very few, although there are a couple of you who are seeing quite a few of this client group.
Interesting. So we will provide you today with an overview of geriatric mental health issues, and specifically we're going to talk about some useful strategies and tools in working with this growing population. And we're going to really cover the population over 65. However, we're going to also ask you to keep in mind that even though you may not be directly working with particular patients 65 and over or 80 and over, you may be working with an unidentified caregiver, with a family member, with a relative that is indirectly impacted by the issues that are typical of an aging population. So one of the things that is very, very important in working with the elderly are the barriers to care, and most important, the pathways to care. And we will focus on that right now. So mental health and aging is full of myths and misinformation. Misunderstanding of what constitutes normal aging versus what constitutes a disease process. We cannot forget about the importance of stigma and mental health, which crosses cultures and class and socioeconomic level. We also need to be mindful of the fact that the elderly are resilient. They didn't just get old because they were not taking care of themselves. They are used to caring for themselves, and they typically do not seek care, especially those in the role of caregivers, who are also at risk of suffering from caregiver stress. So interestingly enough, there are common misconceptions around mental health services among the elderly, and in particular, the elderly that are foreign born. And I'm talking about people that were born either in 1946 or before, and those who were born before 1946 in a foreign country. So in general, medications are very scary topics for the elderly because they have to take so many. When we think about the possibility of taking another pill, they are completely averse and afraid that these medications will lead to cognitive decline, which is another big fear. Now, being mindful of where they grew up and when they grew up and how mental health issues were treated then, ECT comes up immediately. There continues to be a belief that ECT is prevalent in the treatment of mental health problems, although this is not easily verbalized by this group of people or by anybody, for all that matters. And the overarching belief is that mental health problems are treated all the same way, and that mental health problems are all perceived as severe mental illness by these older adults, and even sometimes by younger adults. So age and cultural context are barriers to care. As I mentioned, people who were born before 1946, people who were born somewhere else besides the United States before 1946, and in general, ethnic minorities are less likely to use services. One of the things that over the summer, I had the amazing opportunity of conducting several focus groups in East Harlem around the topic of mental health and aging. And one of the questions I had is what were the beliefs, what were their thoughts, ideas, what came to mind when they thought about mental health? Well, interestingly enough, at least in every group across the board, one person mentioned the fear that either memory evaluations required cables and wires in the head, that treatment required cables and wires in the head, or that somehow they were going to end up with ECT. So we created a health education video to address these misconceptions and myths, and one of the things that we did is to make it lighthearted and fun. We created these interesting hats that integrates these beliefs and misconceptions in a very concrete way to diffuse and clarify these misconceptions. So essentially, mental health literacy across the board in the older adult population is influenced by cultural values, obviously behavior codes, and ultimately this myth and misinformation that we just discussed. So what are some programmatic strategies to increase service use? Well, health education is important. Mental health literacy is very important. We want to develop community programs that address the diverse service needs of this population. We also would like to have the opportunity to conduct outreach to those elderly that are isolated, that may have no family members. And an underserved population are the unpaid caregivers that provide informal care to the elderly, particularly the oldest old and the ones that are frail. And those unpaid caregivers become like part of the family. They are informal family members that take on the role of a daughter, of a niece, to these isolated elderly. They get attached and sometimes feel disempowered to care for their care receivers. So we have some examples of programs that we have been involved in. For example, the Alzheimer's Disease Assistance Center is a bridge between the community and our mental health setting at the Mount Sinai Medical Center. We produce health education talks, and we disseminate these talks directly to seniors in the community. We have a specific caregiver program for those caregivers that are family members who need support, but we extend the services to the paid caregivers because, as I mentioned earlier, we have identified them as really very important members of our care team because they provide information that we would have no access to receive otherwise. And ultimately, we've just started a senior caring type of program, and our purpose is to connect seniors to seniors in naturally occurring retirement communities in East Harlem. So these are services that we have been able to integrate into our Alzheimer's Disease Assistance Center. And one of the things that's important to mention is that these are grant-funded programs. Therefore, the services are free, and this is in many ways a luxury that cannot be replicated. So the majority of patients will find their way to mental health settings through their primary care provider. This is the most common and most prevalent way of entering into care. So we are going to move on to discussing some ways in which we can help you start thinking about the assessment process of older patients, older consumers, older clients, however you prefer to call them. So what tools or strategies do you use in your own assessments of older adults?
So we just want you to notice that there's a chat box on the right-hand side of the panel, and in there, and then there's like a smaller box underneath, you can type in what tools or strategies that you're currently using in your assessments of older adults. And then just make sure that when you send, it's listed as send to all panelists. So let's just take a few seconds now, and it'd be really great to hear what are some of the things that you're already doing, and then how we can help introduce some other ideas and continue the discussion. So again, if you can use the chat box on the bottom right-hand side, and then click Send to All Panelists. That way we can see your responses, and just let us know what are some things that you're currently using in your work with older adults that has been helpful. Okay, so we have one response so far. We have a couple that are coming in. So we have one that says psychosocials, risk assessments, mental status exams, assessing for medical needs, using the PHQ-9, which is an assessment of depression.
These are all very interesting and important points that are being made, although sometimes we don't have any specific tools that we use. We think about working with the elderly slightly different because there are some concerns, particularly comorbidities, medical issues, decline, and the impact of the aging.
So I think one additional comment that just came in as we started talking was that somebody replied, well, I don't really have any formal assessments as I haven't been working with older adults that closely, but one thing I do take into account is quality of life changes. So it sounds like there's a mix of you really using some standardized assessments while others of you are really trying to piece some things together, and quality of life is one of those things you bring into the table.
And that's an important point, quality of life, that we will be discussing, although we are not speaking specifically about a tool to measure quality of life. I know that out there are very, very useful tools that in the future, if we need to, we will address this curiosity. So key factors. I know that you all have some ideas about the comorbidity of mental illness and physical illness. Among the elderly, depression and anxiety are really very prevalent and some of the most important presenting problems when we work with older adults. An important consideration is the risk for cognitive decline. And if I can say I can emphasize one point is the older adults' fear of cognitive decline, even if it's not present. About 99% of the older adults that I encounter in the community when I go to do my memory and aging talks are fearful of Alzheimer's disease. In fact, during the summer when we conducted these focus groups, we explored the ways in which this disease is commonly referred to, and we learned so many different names for this particular condition. And there is so much confusion out there about what constitutes Alzheimer's disease, and the confusion also between what is Alzheimer's, what is vascular dementia, what is normal aging, what is a cause for concern, to the point where we created a video to illustrate all these points, which we are not going to show today, but you might, we will give you a link to the video. So, key point, about 85% of the elderly who come into care are going to be suffering from a chronic medical condition. And what are these conditions? They're hypertension, diabetes, heart disease, cataracts, strokes. So to start, we know that hearing loss is going to impact communication and their receptivity to care and services, to engaging in a relationship. Furthermore, there's going to be a fear of further decline. There's going to be fear of debilitating conditions. And there's going to be worry and preoccupation with their medical care and their medical situation. Some circumstances that bring people into care for mental health services are specifically what I just mentioned: coping with physical health problems, decline, multiple medications, the interaction of medications one with the other, death and loss. That's a major problem among the elder population. Relocation to a new living environment, caring for a spouse with dementia or other disabilities, my caregiver support group, and managing conflict with family members when there's disagreement in the care for a family member. One of the things that we have done in the past is we created a program to help patients with mild or moderate dementia to select a healthcare proxy. And although many of the participants had access to make that selection, they were very fearful to choose one adult child over the other. So family conflicts are very, very prevalent, and they're very difficult to address, as well as elder abuse and the complications that come from these interpersonal difficulties. So depression and anxiety are widely under-recognized, often untreated, associated with distress and suffering, may lead to impairments globally. They can complicate the treatment of other diseases, and they can, make other diseases worse. And those who suffer with depression and anxiety tend to visit the emergency room more often, use more medication, spend more money in their care, and stay longer in the hospital. And these behaviors are indicative that they are seeking for psychosocial care through somatic complaints and through the, let's say, through a door that is not going to lead them into the, into receiving proper care and services. So one of the problems we have worked with over the years is the overuse of the emergency room and the fear of anxiety and confusion between what may constitute anxiety and what may constitute cardiovascular disease. So I am not sure whether any of you have had this experience, but in my experience, many patients come into care because they experience chest pain, and they're frightened that they're having a heart attack, and in fact they're having severe anxiety that can be treated without medication. And at times, these patients may end up taking benzodiazepines because their anxiety is so severe that it needs to be managed immediately by the medical provider. and they end up becoming dependent on these benzodiazepines. And we have successfully created some strategies to decrease the use of benzodiazepines, just teaching the elderly some basic stress management techniques. So memory loss, that also creates anxiety, and it creates a sense of impending doom, fear. Even around ourselves as providers, sometimes it is confusing to understand what is a memory problem and what is a memory disorder. So memory decline is part of normal aging. We are all suffering from some type of memory problem. That's the bottom line. However, a progressive memory decline combined with functional impairments that leads to behavior problems, to personality changes, to the loss of ability to live independently is not part of normal aging. So dementia is not part of normal aging. However, it is prevalent among the elderly, like I mentioned earlier, Alzheimer's disease and vascular dementia. So briefly, there is a slight difference between vascular dementia and Alzheimer's disease. And the complicating factor is that some of our consumers will have both simultaneously, and it will be very different to tease out. And therefore, the way to manage the symptoms is similar because, as you know, there is no foolproof cure for either one of them. And the way in which we have been managing Alzheimer's disease has it works to a certain point. There's medications that are out there that help. However, there is still no cure. So the key difference between vascular dementia and Alzheimer's disease is that one is a stepwise process. The progression is associated to cardiovascular accidents, to TIAs, to a stroke, and these may happen at times without discrete symptoms. Alzheimer's disease is more consistent, progressive, very slow, and it really leads to overall loss of autonomy and independence and the need for someone else to step into our lives and help take care of us. So we have put together a toolkit for working with older adults that is pretty general, but we hope will be helpful in your practices. Since cognitive changes are so important with this population, we suggest the use of the MiniMental status exam, which is an easy-to-implement tool that has been translated to multiple languages, and the training to administer it is quite simple. And although it is not a way to diagnose vascular diseases or Alzheimer's disease, it is a way for you to get a sense of where your client or consumer is cognitively. So it gives you a certain level of orientation. The geriatric depression scale is very useful because it can help you monitor your progress in the care of your consumer. And of course, we cannot stress enough the importance of a detailed history. For those of you with experience working with children, you know that engaging parents, teachers, and providers in the development of a team is very important. And that is an important consideration in working with the elderly because of the fact that they do have multiple providers involved in their care. And at times, there's different providers that are prescribing different medications. So we, as I said, cannot stress that enough. So this is a very choppy example of what the MiniMental status examination looks like. We will be able to send you a link to another website where you can get a good copy so you can review it for your records. And on the side, it will give you an idea of the questions are somewhat confusing, but it gives you an idea of what we're looking for. So for example, we're looking for spatial orientation, we're looking for attentional calculation, and the most important 3 questions are delayed recall, because that is going to help us understand the functioning of the participants' short-term memory. The geriatric depression scale is like, it's self-explanatory. However, I will give you a very quick look at what it includes. And it's a you can help the participants or your patients or your consumers by filling it out with them. And this is a way to engage them in a conversation about their symptoms. And it can help open the dialogue. If you feel comfortable enough with their literacy level and independence, they can fill it out themselves. Sometimes older people have a difficult time with their vision, so I use it as an interactive tool rather than as a self-administered tool, because I have found it useful to engage them in a conversation and a dialogue. The geriatric depression scale is useful in engaging the participant, the patient, the consumer in a dialogue. At the same time, one useful way of working is to explore with your client directly their receptivity to helping you to engage with other members of the family, and especially with their caregivers, because it is not always possible to assess their cognitive function independently, especially when there is a memory problem looming. So there are inherent communication challenges in working with the elderly. So we want to be mindful of hearing loss, vision loss, memory loss. And the fact is that cognitive changes are part of normal aging, and they impact your patient's ability to engage in a normal conversation. Mild short-term memory loss is not pathological. However, it is something to take into consideration when we are working to engage and establish a therapeutic relationship, as well as it is to acquire and store new information. We would like to emphasize the importance of getting the client's attention before you speak, the position in the office, the fact that they need a little bit more time to get focused, the importance of face-to-face interactions, lip reading, speaking slowly and clearly. Keeping your mouth visible is an important tip. For example, when I have had the opportunity to work with older adults, I try to sit face-to-face, and I try to connect with them and ask them if they, how is their hearing specifically. So at times they're able to share the fact that they can that they need to look at my mouth so that they can read my lips in addition to hearing me. I have a very low voice, and it has a high pitch, so sometimes it's hard for them to listen to me. So we try to speak loudly, but we avoid shouting. We try to use short, simple words and sentences, and we are prepared to repeat and to paraphrase what we have said. And we try to stick to one topic at a time. And speaking about sticking to one topic at a time, it is interesting to note what brings people into care. And one of my recent interventions, and one that threw me off slightly, was that I met a very a reasonably older man. He was in his 80s, mid-80s, and he came depressed, and he expressed his sadness and his sense of loneliness. And after several sessions, it became clear that he had been involved with a woman. He was a widower, and he had a girlfriend. and the girlfriend was much younger. And he was very disappointed because he was having difficulties in the bedroom and requested assistance with obtaining Viagra. So that definitely threw me off as a typical problem in the older adult group. However, it is a prevalent problem, and older adults do engage in healthy sexual relationships, and they also engage in not healthy sexual relationships. So we needed to address a variety of topics that were slightly complicated since he had some we had some challenges making sure that he was understanding the complexity of getting involved with a younger woman in the age of HIV and the importance of safe sex and protecting himself. And that, in combination with hearing loss, was quite interesting because the topic is pretty sensitive and we wanted to keep it private and quiet in the office, and screaming about the use of condoms was not one of my most pleasant moments in practice, I must share. So, prevent information overload. Sometimes that's challenging, as I just presented to you this case where I wanted to make sure I got my message across, and the importance of helping this gentleman address and explore his issues was challenging because I needed to give him all the information. I didn't want to lose him. I didn't want to not have him return to care. Asking one question at a time to minimize confusion was also challenging because I wanted to know everything. Who was this woman? Was he paying her? Was he being exploited? It was quite an interesting opportunity. And yes, at the end of our conversation, we summarized the most important point, which was we wanted to see him again. We wanted him to stay healthy and safe, and we wanted to have very high quality of life. However, we were not able to provide a prescription for Viagra because that had to come through his primary care provider, something that he wasn't completely satisfied with. However, he came back and we still see him. So we were very patient in that interaction, despite my urge to finish his sentences. Expectations of inconsistencies were there. However, I wanted to make sure that the inconsistencies were clarified, and he didn't have any emotional outbursts, but he was certainly quite frustrated, and we did experience some communication breakdowns, which has happened often in our caregiver support group, where the majority of the participants happen to be men, Hispanic men caring for their elderly wives with a variety of concerns and worries. And it wasn't a group that was set up specifically for men, it just sort of happened to be that way. And the idea is that we needed to impress upon these gentlemen that their responsibilities were twofold. They were responsible to themselves, but also they were responsible for the lives and the safety of their wives, which they probably couldn't take on by themselves. So there were challenging moments and communication breakdowns interpersonally in the group where different members had different ideas of what was the right thing to do. Nursing home placement was a very tough topic to address, and differences of opinions in the group were also very difficult for the members to express and to manage. So these are examples of communication breakdowns that we expect in the interactions with our older adult patients. So very important to highlight that good communication, although we have stressed the importance of speaking with the elderly. Listening to them is also very important, as it is to listen to everybody across the life cycle. Also to expect some deficits in memory, hearing, or vision, and to engage a family member if the client's deficits are a barrier to communication. And this is not always easy because those particular patients that are presenting with more objective cognitive issues are going to be more protective, or they may tend to be more protective of their privacy because they do not necessarily want to either accept themselves or admit to their families that they are having, changes in their memory. And the flip side of the coin is that depression and anxiety can manifest as subjective complaints of memory when in fact there are no cognitive deficits present. And we do have patients who repeatedly request memory evaluations and memory screenings to make sure that they are okay. So it could run, in all directions when we work with our older adult clients. Another important topic, which I am sure you all address in your practices with patients, consumers across the board, is the importance to check in about cultural context. I think I mentioned earlier that those consumers born prior to 1946 are harder to engage in care. And one important factor is that educational access to education was probably less available to the older old. And education can help people or can mediate psychological mindedness. So it might be harder for somebody born in a foreign country with a different cultural context to engage in mental health services. So time, place, and experiences impact who they are now and how they manage their lives, how they understand their internal world versus the external world, and how they can accept the services that we provide. So cultural sensitivity and checking in, keeping this in mind is also an important point and an important consideration. So we're curious about this particular area, cognitive health issues, and how it presents in your work. How do you address it? How do you manage it? Who is your team, like your support team? Do you have services in the community that you refer patients to?
So we're going to use the same method we used last time. There's that chat box on the right-hand side of your screen. If you can just type in what are some ways that you address some of these cognitive health issues with your older adults clients in that chat box. Make sure it says all panelists, and then click send. And we'll wait a few seconds to get that response because it would be really helpful. I think Mari has done a great job of kind of talking about some of the things that she's done and that has worked for her. But we also saw from the polling question that there are many of you who are also working with older adults. So it'd be great to see how you're dealing with some of these issues. Are you doing anything differently? And you're welcome to also ask any questions too. So again, if you can use that chat box on the bottom right-hand side of your screen, make sure you click send to all panelists and click send, and then we'll get to see some of your responses. Great, so it looks like we're getting a few coming in. So at evaluation I'm just gonna read those off, and then Madi's gonna kind of talk a little bit more about those. So evaluation, refer to a neurological evaluation, and work in collaboration with psychiatrists and neurologists, making referrals to seek resources from the Office of Aging, coordinating services with primary care provider, engaging with family members. Great, we're getting quite a few coming in. Referrals to appropriate service providers, content groups such as art, movies, games, computers. That's really great and different and innovative way of connecting people as well. So you feel free to keep sending those in. Okay, we have one that says they have a neuropsychologist on staff. We refer to the local neurologists and community agencies as well to address some of those issues.
And another important resource that is available across the state is that we have 8 Alzheimer's disease assistance centers across the state of New York that provide memory evaluations as well as case management and evaluation services to patients, as well as support to caregivers and help with accessing services in terms of like senior day programs, overnight programs for those patients who have difficulties sleeping, and so that the caregivers can actually maintain their work. So the ADACs are a wonderful resource, as well as the Alzheimer's Disease Association, and their neuropsychologist is like fantastic. Now, one more thing that I wanted to share as a resource is that also across the state, there are some Alzheimer's disease research centers. Particularly, we have one at Mount Sinai, there's one at NYU, there's one in Long Island, as well as one upstate. And these Alzheimer's disease research centers conduct neuropsychological evaluations as part of a longitudinal study that's called the Unified Dataset, and they provide yearly evaluations to those who are interested in participating free of charge, which is an excellent resource if you have one of those centers close by, because it serves as a monitor. So these participants receive once a year an evaluation, and there is a way to monitor any cognitive changes. So you have immediately a support team that's looking out for the cognitive health of your clients or consumers.
Great. Thank you so much, Madi, and everybody who replied to that discussion question. So we wanted just to make sure, we covered a lot of content, but we also wanted to make sure to give you an opportunity to ask any questions, whether it's something we cover, any additional thoughts or ideas that you had, or even some additional areas you'd like to submit more information in. So again, can you use that chat box on the bottom right-hand side? Click Send to all panelists when you are ready to submit, and let us know what additional questions come to mind, whether it's those of you who are working currently with this population, or if you're not working with them, you know, feel free to ask Madi because she has quite a bit of expertise. Great. So we have a question here that says, how do you manage dual diagnosed elders?
That's an important question, especially as we look forward to working with the baby boomers who may present with multiple comorbidities, but essentially we try to detox. That's our first step, because as you know, multiple patients who are, let's say, using substances may present as though they are suffering from dementia, and we need to make sure that they are free of medication, they are sort of like worked up to make sure that we can assess properly what is going on. So we try personally in our setting, because we have the option, we try to immediately encourage a psychiatric inpatient stay. And it has worked pretty well. We try to do it gently and in a caring way and help the family and the consumers feel like we are taking care of them rather than we are locking them up, although the two things come together. But you know, it is not an easy thing to do for the elderly to enter a geriatric psychiatry unit that is locked. However, it is, in my opinion, the gold standard of care for these types of situations.
Thank you, Madi. So please continue to submit. We have a couple more minutes. Please continue to submit some additional questions. Before we get to some more questions, I also want to let you know that the webinar recording will be posted on our ctacny.com website. The slides will also be available to you. The resources that Madi has mentioned, so the depression scale, the MiniMental status exam, the listing of the ADAC centers, and a few of the different resources that she mentioned, we're going to make sure that those are linked on the same page on our ctacny.com website, where you'll see the recording as well. So if you have other colleagues who weren't able to come on, you're welcome to kind of look at those resources, download them as you wish, and it'll be up for, forever. So I think we have another question. Right. So we have a question from Linda that says, how do you manage personality disordered elders, or elders with really significant and serious mental illness?
I think personality disorders are very challenging across the life cycle, as is bipolar disorder. And there's not a whole lot of literature specifically about bipolar disorders. However, we know that for borderline personality in the younger population, DBT is useful. Although I do not have specific evidence-based practice intervention research for DBT with the elderly, I am sure that some of those techniques are useful. Personally, I have background in dance therapy, and we have created several opportunities for groups using dance therapy as a modality. And of course, as you know, we didn't really call it dance therapy in our setting because that would have been a total barrier to care for the elderly. We called it stress management. We integrated some of the DBT practices, and it was quite successful engaging patients with anxiety disorder, the multiple visitors to the emergency room, the benzodiazepine users, and the overdramatic, hypersensitive types who were super worried about their, let's say, medical condition. And I guess that would fall under managing personality disorders in the elderly.
Great. Thank you for those wonderful questions. And you're welcome to submit. I think we could probably take at least one more question. But what I also do want to point out, and I think it's something Mari had said in the beginning of the presentation, was even if you're not working directly with older adult population, the 65 and over, the 80 and over, chances are you may be working with them indirectly. So, for example, if you happen to be working in a child or family clinic, oftentimes what we've seen in those clinics that it's the grandparents that are the primary caregivers. Or if you're working with other adults, oftentimes they're caregivers for their own parents or other elderly family members. So I think it's also important to take into account that some of these concepts can really be applied, and keep those in mind, especially if you realize that those families, those intergenerational families, your chances are you're already connecting with them right now. So maybe there's some resources you can pass on to them as well. So it looks at this point that we don't have any additional questions. I just want to thank Dr. Ampere for participating in our webinar. If you really found this webinar interesting, if you'd like some additional information, because it is a one-hour webinar, so we did an overview with some concrete things you could start implementing right away, some resources that we're going to have on the website for you that you can start using, and you're welcome to use and adapt. Please, in the feedback evaluation that'll pop up at the end of the webinar, just let us know if you'd like some more information and what specific topics. I just wanted to highlight that we have our next Lunch and Learn. We do these on a monthly basis. The next one is March 19th from 12 to 1 on core components of effective treatment for childhood disruptive behavior problems. So we really try to address sort of the lifespan of clinical mental health issues in our Lunch and Learn, and next month we're going to focus on child disruptive behaviors. This is our contact information. My name is Lydia Franco. I'm with a Clinic Technical Assistance Center, so if you have any questions for us about CTAC, please feel free to email me, and Dr. Mari Ampere's email is at the bottom. If you have any questions about the presentation, feel free to reach her directly. And again, our website is listed at the top. That's www.ctacny.com. I just want to thank everybody again for participating, and have a great day.